Uza, we're here with Sambai Speaks.
We are episode 5.
Wow, episode 5. How cool is this, right? So this is our series that we've been working on and presenting to our audience, you guys, with about our global research project, Sambai. And it's so awesome. We're so excited to talk about this really just life-changing work. It's going to change history and how we think about science and Black cancers. And so just to give you a little recap, we're talking about breast cancer, prostate cancer, and pancreatic cancer. And our study is being conducted by Dr. Melissa Davis, led by her from Morehouse School of Medicine in the US, the UK, Ghana, Nigeria, South Africa, Ethiopia, and Kenya. And so today we're going to talk about work package 4, and I'll let Uza kind of take from here and everybody can introduce themselves, and let's go and talk about the amazing work that you guys are doing.
Yeah, so work package 4, immune biology, tumor biology. We're going to get into what does all of that mean? How does cancer affect your immune system? And we'll let these amazing people take it over. We can start with Dr. Irshad.
Sure. Maybe I'll introduce myself a little bit and tell you.
Yes.
The
And if you
background.
haven't seen her before, she's on our YouTube channel and our videos explaining cancer. We love her. I show her video all the time. It's so great.
So my name's Shiba Irshad. I'm a breast cancer oncologist. So I treat women or men with breast cancer in London. But also I am a group leader at King's College London, looking after a team who are trying to investigate how tumor cells and immune cells talk to each other, specifically focusing on a group of patients where standard of care treatment doesn't work, so treatment-resistant cancers, and how we can kind of educate the immune system, which we'll get into a little bit more, to better sort of engage with the tumor cells, so actually our own immune cells can also fight the cancer. So some of the work that we're involved with is trying to develop new immunotherapies for patients where other standard of care treatments don't work. So that's me, but the question itself, I think, was a bit of a broader question. So either I'll keep going unless others want to sort of, because this is more meant to be a conversation, I guess. So, but broadly speaking, if we talk about why is the immune system important, or why are we even looking at it in this context, I think it's increasingly becoming clear that the tumor cells don't exist on their own. They really do speak to the environment around them, and the environment around them is often immune cells, which usually keep things in check. So actually, a lot of the times, every day, our cells will make mistakes and have sort of mutations which have the potential to become like cancer cells, but our own immune system will engage and essentially eradicate those cancer cells. So, but every now and then that process becomes dysfunctional and that cancer cell is allowed to sort of progress. And the cancer cell has things that it can do to make the immune system not work as well, so that process can kind of that process of being able to find a cancer cell and get rid of it, or find a cell that is not normal, that process doesn't work. So it's really important for us to understand what are these immune cells that can actually talk to the cancer cell and what has broken down in that communication. And we haven't fully understood. It's quite complex. There's lots of different immune cell types. And more importantly, what we now recognize is that it's a really dynamic process. It changes. It's different by ethnicity, but our diet, sort of infections, the immune system is quite dynamic. So understanding the dynamic aspect of it makes it even more complex. But Sambai is, I'm sure, going to sort of, we're going to tackle this at a global stage, which is what's needed to really understand those interactions from all the other bits as well. But maybe I'll let Nigel.
That was so great. That was the best explanation I've heard of like an immune system. So thank you for that.
It really was.
Because you gotta talk to me like I'm a 5-year-old. I say that all the time, but because the science is like, woo. But everybody has an immune system. Like, what do people need to know? Like, and everybody can influence their own immune system by what we eat, how we act, where we live, all these things, right?
So it's like strengthen your arm.
Yeah. So great.
Let's go to Dr. Mongan.
Well, thank you, Zoe, and thank you, Ricky, for inviting me to speak today. I'm Nigel Mongan from the University of Nottingham in the heart of England. It's the privilege and honor of my life to work with Dr. Melissa Davis, Dr. Yates, Dr. Irshad, and the whole Sambai team. If ever there's a project that's going to change the world and improve the world for better and bring justice to how we treat and support cancer patients, it is Sambai, because it's rooted in our collective values. And I just can't say how proud I am to be part of it and how committed we are as an institution to supporting this. And we're going to help expand our understanding of the things that Dr. Irshad just talked about how the immune system works in different individuals, because it is an individual disease. Each individual person has that personalized experience. And we also want to get to the point where we can treat that individual with the treatment that will benefit that individual. And we want to get to that era of personalized medicine so that we can precisely target cancers in people, reduce side effects. Now, Nottingham has been taking an approach to this for over 30 years. So we're a wonderfully diverse city. We have people from all over the world. We were enriched by the Windrush generation from the Caribbean back in the 1950s. We have a diverse population. And 30 years ago, we started to recruit patients into a study where we can understand the disease in individuals from across all different ancestries. And that knowledge is foundational and fundamental to some of the tools that are used to inform, in particularly breast cancer treatment. So the Nottingham Prognostic Index is a tool used internationally to help inform cancer treatments. We'll use that information now to help inform some of the studies that we're doing with Dr. Yates and Dr. Irshad on breast cancer. And again, we're just so proud that Nottingham as a city, Nottingham as a population that is diverse and welcoming and inclusive is being able to play a part in this project that will really benefit patients globally. So again, I'll hand over to Dr. Yates about how we're going to do that collectively, not just in breast cancer, but also in prostate and in pancreatic cancer. Thank you, guys.
Can't wait to see you soon.
Yeah,
Can't wait to welcome
really,
you.
yeah, no, that was really amazing. So yes, I'm Clayton Yates. I am professor, or actually the John Lewis Professor of Pathology and Oncology and Director of Health Disparities and Global Health Equity at Johns Hopkins. I'm also co-director of a prostate cancer transatlantic consortium, largely based in Nigeria. We have over 200 members now, and over 36 sites throughout West Africa, where we've been, I would say doing the work, from, educating patients to educating physicians, helping, providers adhere to standard of care when necessary or augment that for these particular communities. And then also on the back end of this, doing research. And so to answer your question about tumor biology, I think what some of the things that I can add from the really amazing explanations from Israel and Nigel is that what we're seeing is that this tumor biology is different by race. So, I think Israel.
Say that again. Say that again.
So
Tumor biology.
this tumor biology that we're saying of how cells evade the immune system, how these cancer cells use processes that they use to become more aggressive. And, we talk about that word metastatic because, that's the real lethality of the disease. There are different processes that are happening by race or ancestry. And so this is what Sambai really helps to break down, is that we're seeing that this biology is being augmented in a person with certain degrees of exposures or certain degrees of their genetic ancestry, right? And so there have been pockets of information that have been that we've been able to glean from over the years, but never coming together in a really comprehensive way with enough power and enough patience to make meaningful contributions. And that's sort of what we seek to do. I think the real importance of tumor biology to individuals is that that's how we design current therapies, right? So in our world of now what we're calling targeted therapies, right? So we have, chemotherapies that I like to say we're just throwing the kitchen sink at it. But when we start talking about targeted therapies, these targeted therapies are based on biology. They're based on how cells are utilizing certain genes to progress their tumor or evade the immune system. If we can imagine a world, if that biology is different by race or ancestry, and we're developing therapeutics, then will they be substantially beneficial in the populations that we're interested in? And so those are questions that we need to ask. And I'll say just a bit that I'm really excited about is that through our consortium and some of our earlier work, we just opened up or just were funded to open up a clinical trial in Nigeria. Just doing that right now on 60 men of African ancestry who have a specific genetic profile that will respond to a base therapy and a neoadjuvant immune therapy because of this crosstalk that we've been, or biology that we've been covering for some years. So again, this is how we translate this. This is a very small, right? But this is how we take the biology that's important in Work Package 4 and translate those to therapeutics.
Right. So those men have a shot that they would not have had because of this research, but you've been able to isolate something special about their specific cancers that you're now going to solve for. That's so awesome. Also, you just got a big thing happen, didn't you? Talk about that, Dr. Clayton. Don't.
Oh, well, yes. We were just awarded a Cancer Health Equity Grant, 13.1 million.
13.1 million. Hello.
Yeah, very, very, very excited. So it's a cooperative award through Johns Hopkins University and Howard School of Medicine and their Comprehensive Cancer Center to tackle disparities in this local Baltimore area. So I think, Ricky, you know that I was in Alabama for 17 years and now I've moved here to this Baltimore, Washington area. And what I was alarmed is that some of the most significant disparities in the U.S. are right here in our backyard.
Right here.
Right?
Okay.
Yeah, right here in our backyard.
Yeah.
So we thought that
horrible. Yeah.
It's really horrible, and coincide that with some of the most amazing and world-renowned institutions, particularly hospitals, are also in this area. So we thought that Johns Hopkins and Howard University should collectively tackle this approach, and so it's a multi-pronged approach where we have community outreach, and not only community outreach but training the next generation. So there will be high school programs for high school students to get them interested in the science, to understand, ask the basic questions like you just asked us. What is tumorology? How does that relate to race? Also, not only the high school and the graduate students and residents, but also the junior faculty, ensuring that the brightest ideas get brought to the forefront and they get the nurturing they need so they can make impact, particularly in our communities. And so we're really excited about that award and to kick it off.
And we're happy to help you however we can,
It's incredible.
Yeah,
and Ricky, thank you for serving on our advisory board.
But I have an idea for you that came up yesterday. I'll talk to you about it later. It's a really good one. So Al, so every team we have has, are so blessed to be able to have a patient advocate on our team. So Al, and I know Nigel has to go in a little bit, so we'll get back to you to talk before you leave. Okay, real quick. But Al, I love you, Al. You told me you had movies, dude, but we'll talk about that. I'm gonna post about that. I'm gonna have to look that up now.
Hi guys, and I trust everybody's doing well. I'm the latest member to this work package, and so therefore I'm somewhat limited. However, I am a 13-year survivor of advanced metastatic prostate cancer, and this is what makes me, I believe, a wonderful addition to the team. And, I really am looking forward to sort of working with the guys much more in depth. Epigenetics actually came about through Professor Yates, because we had a conversation in New York when I was there talking, and it gave me a real insight to really what is going on. And I thought, yeah, this is the one for me to get involved. And I'm really looking forward to really getting involved further. So yeah, there you go.
And you live in London. You've done a lot of great work in the community with prostate cancer, and
you're a youth mentor.
And youth mentor. So all the good stuff that you're doing, and we're going to post up, about you on our social, so people know you better. So you guys, thank you for laying all this out. I think that we are all so blessed to be a part of this. Melissa's such a badass and such a great commanding leader. So why don't we start with, you know, your personal why, and you know, and
Yeah.
I know, Nigel, you go first because you got to go. Like, you know, your hearts are all here. Your hearts are all here. But is there anything that kind of is intrinsically motivating you to do this work?
Well, thank you, Ricky. And let me just echo, we are so lucky to have Alf on the team. So thank you, Alf. Yes, so we all bring our personal motivations, and it's something that we talked about, Alf, Clayton, and I, a couple of weeks ago. I remember the phone call in my home when my father picked up the phone to learn that his mother had a metastatic cancer diagnosis. And when that happened 45 years ago, it was a death sentence. And I was a very young child, but I remember the pall that call fell over our family and our house. And to be honest, we've never really recovered from it 45 years later. And my father certainly has never been the same person again, because he knew what was going to happen to his mum. As Clayton said, they were going to throw the kitchen sink. So the chemotherapy was torment for a loved one. And I didn't understand what cancer was. I didn't understand what the cancer hospital was. I didn't understand that there was biology behind it. But it stuck with me as a child and growing up, and that's what has motivated me to dedicate my life and career, knowing that I have a family history and risk of cancer, and this particular one will be one that will affect my son as well as me, that I'm not going to leave anything undone that I can do to improve this for my family, but for everybody's family, because we all deserve better than where we currently are. And so it's a deeply personal motivation, but there's no better personal motivation. And I have to say, the reason why I'm stepping off the call is the best possible reason as well, because we have a exciting new drug that we're trying to get into clinical trials, and we have a meeting at 3:30 with some of our pharma partners to have a discussion about the practicalities of that. So I'm so enjoying this, and I wish I could stay on. But again, I want to thank you, Ricky, for your convening power, your energy, and your hashtag GSD. I'm fully on board for that, always. And
I
I'm
used that in
again,
my lab meeting yesterday. I said that.
yeah,
And we'll see you soon. And we're going to record something when I come over there in a couple of weeks.
awesome.
So we'll
Great.
record and we'll have many more videos. So
Yeah. And there's
thank
only love in Sambai, and that's why I think that it's just awesome. So again, it's a privilege to be part of this, and it's an honor. So apologies for having to step out, but thank you again for
you.
allowing me
Thanks
to be
for
part of
coming.
this. Okay, thank you.
Thank you.
Dr. Shiva, what's your why?
What's my why? I mean, there are lots of, I could go back all the way to when I was a kid, people in my family and things, but actually I've been thinking about this more recently because I just put in my promotion paperwork and I was sort of looking back at why. And if I'm honest, it comes back to my patients. So every now and then I meet some patients that just, you know, even though, you know, some of them haven't survived, they are with me still. And I'm always, I wish I could have done something better because we have, you know, we didn't have anything else to offer. So I think that's what drives, if I'm honest, that I genuinely believe that I'm also really fortunate to be around at a time where there is potential for us to find the cure for stage 4 cancers. And immunotherapies for me, which is why I did a PhD in immunology, is that I truly believe that if you can get your own immune system to re-engage, there is potential for us to be starting to counsel our patients with stage 4 disease with, yeah, I can, you know, we can cure this, similar to what we do with early breast cancer patients, for example. And I sort of feel quite privileged that actually, you know, I'm an oncologist at a time when I might be able to do that. So I think that's what drives me. And yeah, like, you know, recently I had a 29-year-old patient who I developed a very close relationship with and, you know, looked for trials all over. Unfortunately, she passed away a few weeks ago. And, you know, I really wish that we could have offered her something more, even though we tried. I think we tried a lot of things, but just, so that's one for the general, the why. But in terms of Sambai, if I'm honest, I think what really shocks me is that I work in a system which is NHS. So actually, you know, funding is not an issue in the sense that any patient that I see, whether white or black, they will be treated in the same way. I'll offer the same treatments. But we looked in our own database, and actually there is a disparity in our survival, even within our own clinics, in terms of Black women do not have as good a survival as the patients that we treat who are white. So to me, the fact that you're seeing the same doctor, I'm prescribing the same drugs, but I'm not,
You're dying.
you know, the survival is different, tells me that actually exactly what, you know, Dr. Yates said, that tumor biology is different, but also we're giving drugs that were developed in, you know, following targets that have come from white patient populations or data sets. And the trials mainly are testing these drugs in white patients. And so it doesn't translate in real life. So actually you see that disparity. So I think that really shocked me because we looked back at the data set and we saw that. So when the grand challenge came about, I think I emailed Melissa and was desperate to be part of this team. And so I think I emailed her a few times to say, please let me in. And I can't tell you, the atmosphere in the team is also, you know, I'm part of quite a few other programs. You know, there's often lots of big egos and all of that, but I'm loving Sambai because we're all in it for, it's about papers and our own kind of, you know, it's actually about the bigger pictures. So that I could talk about forever, and Melissa and all of that, but I won't. But I think for me, I think that's what Sambai specifically, I'm committed to this mission essentially. Yeah.
It's backed by love, and you're
Yeah.
a wonderful addition to that. You're an
Yeah.
asset to this
Yeah.
group
Yeah.
because you're in it for the right reasons and you have the passion, and you're a provider that looks at your patient as a whole and not as a patient, but as a person. That's really what matters here.
Trying to keep them alive. Yeah. So Dr. Clayton, you've known Melissa the longest of all of us. I think that's such a, you know, I think your relationship with her and the work that you guys have been doing together is just was kind of the prelude to everything that we're doing. But what's your why? And talk about
Yeah,
disability too, because you're, you know, you have a lot of history that you're being shy about.
Well, you know, my why, yes, but listen, I've been working for probably too long that I can remember. But, you know, my why, even before that, did start when I was younger. So my grandmother, I remember growing up with my grandmother who had breast cancer, who had a mastectomy. Now, she had it before I can remember, but I remember her having the mastectomy, and we having to deal with prosthetics and so forth, and just being a part of my normal life, like as a grandchild. And then at the age of 13, my grandfather passed of prostate cancer. So my grandmother had breast cancer, but she had a mastectomy. She went on to be a part of our life. But I remember just dealing with that and having to go through those processes. And then my grandfather was diagnosed with prostate cancer. He was my real, close buddy and friend, baseball buddy, and we shared a lot. And then he passed away, but we didn't talk about it. And I wanted to know why. So then I started developing that sort of itch that, we need to figure this out because something's happening in our family, right? So both my grandmother and my grandfather on my mom's side, on my maternal side, definitely, had this disease. And so dedicated, my career to prostate cancer, not really still understanding the disparity. But then when I got into training in graduate school, we would start to write in our manuscripts. We would say prostate cancer is 60% more likely diagnosed in African-American men and twice as likely to die. And then we would never do anything else about it. Like we would just go it would always be at the first the first two sentences, and then we would not ignore it and just go ahead on. And when I was a graduate student, sort of ending my career and deciding what I wanted to do, I said, we have to focus on this in Black men. And so this is some of the genesis of this work, because Melissa and our relationship sort of bonded around that, because at that time, people did not recognize that there was a different biology. We did not recognize that there was a different ancestry, or that there even could be the possibility that these things could be different.
The fact, right?
There could be different mechanisms. So I like to think, those are the sort of whys. I've gone on to have the unfortunate pleasure of my grandmother passed of pancreatic cancer. My aunt soon moving here to Maryland, who I was, really close with and thought I was going to bond with here in Maryland, passed of colorectal cancer the first year I moved here. And then my cousin just informed me yesterday that she has lung cancer, right? Right. And so now we're dealing with
all the Black cancers happening in your family.
And all of this is happening in my family. And luckily she has a target, so she's getting targeted therapy and it's regressing and so forth. But again, this is really hit close to me. And I feel like it's something we can do, we can solve, we can do something about. And Sambai embodies that. Sambai will give us the power to be able to do that. I think also what I really enjoy is meeting, when I met Alf, for example, taking what we do, this knowledge that we have, I'm calling in the ivory tower, right, in our academic institutions, and making sure that gets out to the people, right, gets to people who need it, and then that gets disseminated out. And again, with you guys in this platform that we now have here, just amplifying that message, I think will also be impactful on a global stage, right? And so, just being a part of this processing, meeting you wonderful people, and who all share this passion, I think is really the why for me today. The why for me earlier was how I got in. The why for me to keep going today is I think we can really make an impact and save lives.
Love it.
Absolutely.
We will. We all will. I'm
Yeah,
so
we're
excited.
already making history.
Yeah. Al, you're here. You're your why.
That's so right, Ricky. That is so right. That's my why.
I know.
Do you
I'm
know
on 13
something?
years too, so 13 is a good number.
Oh, well, that's excellent to hear. That really is.
Yeah.
My why is kind of similar to Professor Yates. You see, I lost my mother to breast cancer in 1983. 6 months later, her sister passed of some sort of leukemia. 5 years after that, their brother, my uncle, passed of prostate cancer. I remember talking to my uncle before he passed, and he told me about this pain that he got in the mid back into the lower back, and it sat. I remembered it, but the fact that I saw 3 members of my family on my mother's side, that meant to say one side of my family was wiped out because of cancer, really hit me. And when I got diagnosed, I kind of said to myself, I've got to do something. I can't just be another victim and not be able to pass on information to the family so that they can understand what's going on within the family. And obviously, prostate cancer disproportionately affects Black men. I never knew that until I got prostate cancer. So my why is I've got to investigate. I've got to research. I've got to go in depth and really work with different organizations. Sambai came about, again, because of Professor Yates. And when I looked at it and when I got involved with you guys, I realized I was home. And that, to me, is a very important place to be. I was home. And, so that, these are my whys.
I love it. I love it.
That's
I love it.
We want all of our patients, a part of the study, to feel that way. And that's why we're here.
Yeah.
Help the scientists really translate the words.
And help to do that. Yeah. You have a question for our people, or?
I was thinking about, we talked about the immune system. I was wondering if we could explain immune profiles. Is there any testing for that? So I know we get sick naturally. We have a cold or we get the flu, and so we know something is wrong with our immune system there. But I guess on a deeper level, we're going to be looking at immune profiles, right? So what does that mean?
And how do you know if you have a good immune system? How can we help
the
people think about it? Like, what are you doing? Like, we're all getting vaccines, and God help us now, we may not get them anymore. What the hell? I don't want to go there today. But be like, let's talk about, like, are there things we could do? And I know you can't prevent breast cancer. I think that, and I think the whole concept of early detection, but when you're like looking at immune systems, are you things you can tell us that, okay, always do this, never do this? And I know it's going to vary by biology and race and all these things, right? And ancestry, as you're saying, but are there basic things people could be at least thinking about it? And what you're thinking about as you do this work?
Loaded question, but.
Yeah. Shall I take it first, or?
Yeah, go for it, Doc.
So first, to just explain what do we mean by immune profiles? So there are probably two different aspects to that. So we'll be studying two different types of immune profiles. One is in the blood, so what we call in circulation. So these are where we take some blood, we spin down the cells that are floating around in the blood. And then there are different types of immune cells that exist in the blood. And we can, when I say different types, it's not just different types of immune cells, but also different states in which these immune cells can be at different time points. So we have assays within our team where we can actually take small amounts of blood and really look at all of these different types of immune cells and the state that they're in by doing certain tests in a research setting. This is not necessarily to go out and we would do. So that's what an immune profile in the circulation is about. But there are other components in the blood that we also want to look at, like plasma or serum, where you get small proteins or that are secreted by these immune cells or other cells that are floating around in the blood as well. So these are not necessarily cells, but small proteins. But we know that they have function. They actually do, they're like signaling pathways, or so they signal to each other, or they can influence the behavior of a cell in one place to the other. So we want to understand that, the immune profile in circulation in black and white patients from both sort of breast, pancreatic, and prostate cancer patients, and how those are different in the two settings, particularly how by sort of how that changes as well, I guess. But what we also know is that there are immune cells that go when there is a tumor, there are immune cells that get inside the tumor and are trying to sort of, there is this talking that happens between them or not, they may just be sitting there. But that's what's called the tumor microenvironment, which is where we also want to study the immune profile that is present within where the cancer itself is. So we have to use different specialized techniques to really analyze those cells and how they're talking to each other, how much distance there is between the two, really understand that. And again, we're really fortunate, I would say, at this point that the technology has developed that we're now able to look at these interactions in a way that we just would not have been able to do even sort of 6-7 years ago. We can now really look at this at a level, really hone in, take a deep dive into that tumor and what is it talking to. So that's what I would, Dr. Yates may explain that a bit better, but I would say sort of broadly speaking, those are the two immune profiles that we are specifically interested in talking about. I wanted to say more and I've forgotten your second question. There was one bit that I really
that's great. That's great. And you actually showed me a picture that you said you didn't want to talk about yet of two different cells, a black one and a white one of TNBC. Remember? And so you'll tell me when you're ready to talk about it. But that was so vivid in my mind in terms of how there are so many differences. And I kind of want to make a cartoon of this. Let's think about that. Like when you start talking about cells talking to each other, like I have this vision in my head of what that looks like. So we're going to try to bring that home for patients and make something, animate something so we can explain it better.
I've remembered what else I wanted to say.
You go, girl.
I remembered. In terms of, I think your second bit was what could we tell patients even today to go out and look for, and what could they? So I think we have to be really careful because, at the moment that what we're doing in Sambai is to really understand this. And what we also know is it's complex and we need to study that before we go out and tell our patients you need to be doing this so that your T cells or T regulatory cells are at this level. We don't know that. I would also say that, there is clear evidence that some of the blood ranges, the normal ranges that we think are normal, again, are based on a patient population that is skewed towards the white patient population. So we are now starting to really understand that as well, that actually it's different for different patient populations. But there are certain things, if you had to say to me, come on, there must be something you could say. There are things like vitamin D, for example, that there is clear evidence that affects the immune system. It is easy for us to sort of make sure. In fact, I'm currently on vitamin D rapid replacement because it's so low.
I am too.
Exactly. And, you know, there are certain things you can go to your doctor and say, I want to optimize my health. What can I do? So I think there are already things that supplementations and things that we should make sure that vitamins and all of those are, you know, good. But I think if we're now going into deeper immune profiles, should my T cell level be this or that? I think that Sambai will answer in a few years, but I don't think we're there yet. So
Great.
Yeah.
That's perfect.
On a very
I'll just
basic
add a little bit. So I think, Sheba did a great job about immune profiles, but I'll just add two things. One, we're seeing that the immune profile is different by the race and ancestry, right? So again, if you think about this immune system, right, and I'm gonna sort of bundle your question of what should we do? It should respond. It should be there in the backbone, and then when you encounter a cold, a virus, cancer, it should be fine-tuned and ready to respond. So as it turns out, these African American based on ancestry have different responders, okay? And there are signals that allow them to respond. So for example, we see very, very, very clearly, particularly in prostate cancer, normal men have increased inflammation. Just normal men. There's an increased inflammatory response. This is really interesting, right? Because if you sort of talk about inflammation levels, and again, this is not quantifiable from a level perspective, but it's qualitative enough to say that if you sort of have this chronic low level inflammation that's occurring and contributing to the tumor, you want to make sure that your immune system is optimized by supplementing with vitamin D, by exercise, by good diet and nutrition, that you can overcome sort of this sort of inherent sort of inflammation. The second thing I want to sort of iterate is that, and what's really, really interesting in Sambai is that while breast cancer is actually what we call an immune active tumor, so that means immune cells actually go to the tumor cell, although they get turned off. In prostate and pancreatic cancer, we don't get immune cells. So the immune cells are completely evaded from the tumor.
Really?
We have this dichotomy of biology where in breast cancer, why you started talking about earlier about Keytruda being so beneficial, because the T cells actually go to the tumor. They get turned off. Those drugs like these immune therapies turn it on. In the case of prostate cancer, they don't even go there. So the immune therapies have not, in prostate and pancreatic, have not done well. And those patients, right, because we call them immunologically cold. So the profile of those patients in prostate cancer and breast cancer are different. Now, what is becoming a little bit clear is that in African Americans who have this inflammatory disease, there may be a beneficial profile because of that inherent inflammation that we can target, but we need more evidence to do so. But we do have data. Like I said, we developed a clinical trial here at Hopkins. There's another one by Dan George, as well as Oliver Sorter, and prostate tumors that have shown that African Americans who get on immune therapy actually respond 2 times better than Europeans in prostate tumors. But the European patients don't respond because the T cells or the immune
So say that again. So you're doing some studies where Black men, immunotherapy is working with Black men when it didn't work with white men on prostate cancer.
Absolutely. So the first study was done by Oliver Sorter. He was at the University of New Orleans. Now he's at Mayo Clinic in Rochester. It's now been followed up by Dan George at Duke, and we're opening up another one now that's going to mimic a version of that in Nigeria at Ilorin University.
That's the 60 patients you're doing in Nigeria.
That's the 60 patients. That's correct.
So we're testing something that basically immunotherapy really came out with lung, right? Like years ago, like 10 or
came out with lung. Again, another tumor where, again, there is an immune response, but then the tumor is very smart. It learns how to turn it off, but at least the immune cells actually recognize the tumor and they go there to that microenvironment that Sheba was talking about, the microenvironment. And then these drugs are allowed to turn it back on. But these other tumor types, just in the clinical trials, again, because diverse patients were included, they're immunologically cold. So that means these immune cells don't even go to those tumors. They completely evade it. So that profile is different.
Yeah, but what I hear you saying is that Black men are now going to be able to benefit possibly from
I think
this.
something that seemed like it was this high inflammation could be turned into a benefit because we now have a targeted therapy.
Right, right.
They weren't enrolled in those earlier trials that we now
Yeah.
think they can benefit from.
Yeah, and
the
because
early
the
data
trials were
and the
done
early
on-
phase 2 data is very encouraging. It's very encouraging.
That's great. And because those trials were done on white men, we could have found this out years ago if we had
We
black
could
people trials.
if we'd had
Don't get me
diversity.
started on that. Okay.
Yes.
Okay, that's cool. All right, so do me a favor. Define when you say ancestry. What do you mean? for people?
So when we say ancestry, first of all, I'm gonna decide race. So race is a social construct that was applied, right, to an individual, and it was just, determined, right? We're gonna say Black, African American, whatever. When we say ancestry, we're actually talking about genes within the DNA or regions of the DNA that are unique to one population or another, right? So this is actually quantifiable. So some time ago, there was a group, typically they call it the haplotype, the HapMap group. They went around the world sequencing different people in different regions across the United States, as well as UK, as well as now Africa, and we're the African nations are only being increased. And what they found was that across the entire genome, that means all the regions of your DNA, there were certain regions that were specific to areas that people lived in. And we were able to track that back to calling it a specific ancestry. We call them these SNPs, or ancestry informative markers. So these ancestry informative markers are unique to a population, and then they're passed on from generation to generation. Okay, it's the basis of Ancestry.com, 23andMe, all of they're sort of running it. So we're able to now understand. Now, what the real issue in the relation to that, to tumor biology, is that the regions in your DNA are not just there. They actually code the regions in your DNA is the template. And I think we've all heard the DNA is the template for what you are and who you are and what, is being expressed in your body. They code for certain genes. So you have these regions that are different by ancestry or by group that code for different genes. They're turning itself into a different regulatory system as to why we sort of see some of these different inflammatory genes associated with a person's ancestry. When we talk about race, we are able to use ancestry to exclude what is a profile based on a person's genetics versus their environment, right? Because race would have to be environment, because race, even though it's a social construct, will be a proxy to all the things that a person has to deal with as to being into one category versus another that excludes the genetics.
Yeah, and that's even some of Dr. Lauren's work,
That's correct.
her data about the two things that always blow me away there is that Black women who have equal health insurance to white women still have a 66% higher mortality rate of breast cancer. Black women who live in the same high socioeconomic neighborhood as a white person have 126 higher mortality rate than the white women in the same neighborhood. That's crazy, but that totally validates everything you're saying here in terms of the biology is different, the immunology is different, the ancestry is
Because we
different.
sometimes say it's due to lack of access, and but that proves,
that
it's deeper than
it's way deeper than access. So, gosh, we have so much work to do and so many things. You guys want to, tell us anything else? We got this audience for a couple more minutes, and just, tell us what you, like what are you going to go do today? What are you working on right now? Right?
Superheroes out in the field.
I know.
What am I working on right now? So we have a study called the Outlier Study, which is basically where, so I often feel that a lot of research happens on, in clinical trials and things, we often look at patients that fall in the middle, but there are often patients on two extremes that either do really, really well in terms of the response that they have, or unfortunately just do not respond at all. So what we would call the rapid progressors, and the other side being the exceptional survivors. So this study specifically is focusing on stage 4 cancers. We call it the Outlier Study, and we've been sort of essentially inviting patients to give consent to study their immune profiles and tumors at these two different extremes. So I think that work I'm quite excited about, because I think we can learn from these streams on how you could turn a bad immune tumor microenvironment into a good one by learning from someone who is an exceptional survivor and vice versa. So that one excites me quite a bit. I'm hoping that we'll get some novel sort of understandings from that. So there we go.
And
Cool.
it better informs the work that you're doing.
Yeah, yeah.
And with Sambai as well.
Yeah.
Dr. Gates, what are you working on? You have a lot going on, both of you. We're
Yeah.
many. So
Well, yeah, that's a great example. So yeah, so later on today, I have a few things I have to do administratively. But I think some of the most exciting work is that, you know, in addition to, you know, I think what Sheba mentioned, you know, one of the major challenges today is understanding who will respond and won't respond to our current standard of care. And so what we're sort of adding to that piece is a machine learning AI approach where we'll be able to identify from a histological section of the patients, do you have these immune cells? Which ones are there? What is their transcriptional profile? And if they are there, then can we match that with a therapeutic from the time of diagnosis so that we get it right the first time?
So you just said a big word. What's histological?
Histological, that means, all right, so sorry, let me back up a little bit. So we talk about cancer, right? But the only way to definitively diagnose cancer is to take a biopsy. And once you take a biopsy, it goes to a pathologist, and the pathologist looks at that, the tissue, the actual tissue, and determines how close it looks or how abnormal it is to the cellular structure to, you know, a normal cell versus if it looks different, and then we give it different stages based on how different it looks, right? The cells look. That's called histology. That's
Okay.
that's a histo.
Right.
thank you.
Thank you.
Tissue
Right.
section, right? That's
Right.
a tissue section. So that's a part of the original diagnosis, whether you for any cancer type. And so our goal now is to take that sort of basic, what we've been using since the beginning of, you know, cancer treatment and diagnosis. We've been utilizing this sort of basic morphology to sort of stage and grade. Can we add these new innovative tools such as machine learning and AI to better, you know, to more rapidly and more accurately diagnose these individuals, but also can we train them? Because what is very clear from the literature is that we're not the first to do this sort of digital sort of approach. But when people utilize this digital approach and they perfect them and they publish these great papers and they get ready to employ them, again, just like the clinical trials, when they do it on non-diverse populations, when they actually go to other,
Right.
not just African Americans, but any non-white population,
Right.
the sensitivity and specificity goes right down. So we're building ours from scratch with samples from Sambai, by the way, or Sambai-like samples from Nigeria. Today, we just got in a big shipment of samples from Nigeria. Yes, but we got our Nigerian samples in today. So we'll be adding those to our African-American samples to make sure that when we develop our algorithm and we develop this AI approach that it captures the diversity across the diaspora that we would see and that we can utilize these tools within Sambai and clinically, hopefully going forward. So I'll be
And
going over some
we're
data
gonna-
from our graduate student today about this because he just got back from his break. He was studying for medical school. So I'm going over some of the data with him about that today, this afternoon.
And we're going to do 40,000 people in the study, right?
We're going to do
Across the-
40,000 studies. And again, you know, some of the things that we're doing in Work Package 4 are really expensive. If we've been able to use a machine learning approach, right, to sort of simplify that or triage those people, it would be really beneficial because it's, you know, the 40,000 number will be very, very expensive. But if we can sort of collectively utilize this and put it into an algorithm that we can then apply to the patients that we can't be able to assay in Work Package 4 to the remaining patients in the other work package, it would just be amazing. So
Incredible.
we're hard at work.
Yeah, AI kind of scares me, but we're
Yeah,
jumping on
yeah,
the train and
yeah.
let's use it
Let's
for
use
the
it
research.
for the right
I
thing.
think I think it's here. But you know, I think we have to use it responsibly.
Yeah.
And I don't think we can avoid it because that train is left. So you know, our goal is again, just like all the other things that sort of launched, to make sure that the patients that we are interested in are included and that this trained correctly and that it's used correctly and deployed correctly.
Yep. So I think AI is another episode, an upcoming episode. We'll talk about AI as another Soundbite episode. So you guys are so awesome.
Incredible.
Thank you so much for your time today. I know it's all very precious and we want to get you back to work, but we're so grateful for you. I can't wait to see you soon.
Monday, I think.
in a couple weeks, and Clayton will be back. We owe you, and you're supposed to come to Annapolis next, Clayton.
Yes, I have to. I'm coming to Annapolis. So.
Yeah, so you got to come to
But
Highland
it's
Beach.
probably
And-
only a 15-20 minute drive for me, so I need to come out and see
Yeah,
you.
you got to come to the beach.
Yeah.
Come on over, and I'll see you soon too, Al. Over the pond. So
Yeah,
thank
looking
you so
forward
much,
to it.
guys. Yeah, and we're so blessed to have you and do this work with you. Any closing remarks, my sister?
Let's for the community, let's make sure we're making our doctor's appointments and getting our blood work done. I hate doing blood work, but it's necessary for
Yeah.
on a basic level, the things that Dr. Shiva touched on.
Yeah,
Just making sure our levels, checking with our doctors that our levels look right. And I'm getting on some of those supplements, if
vitamin D. We heard you. So and cancer community, look at all the work we're doing, you guys. We're gonna save you. We're gonna save the world. So thank you.
Thank you.
Sambai
Thank you.
Speaks.
Thank you.
See you next month.
Thank you,
Thank
everyone.
you. Take
Bye.
care. Bye.
Love you guys.
Is that it? We're good?
We're good.
Oh.
All right.
Oh, okay. Yeah.
Take care.
We're
Professor
good.
Carlo.
Wake up.